It's lovely to meet you all and to see you, and I feel a bit weird talking to not a room full of fifth-year medical students who just want to pass an exam. Yeah. So I came to talk about some hormones, and I think some of the things I was going to say have already sort of been touched upon, so I might go a little bit off-piste, but we'll see where we go. So I feel like we should live in an age of enlightenment about hormones. Primary school children are being taught about going through periods. Davina McCall has made talking about the menopause kind of as common as talking about soft furnishings. Netflix has cartoons about puberty and hormone monsters. And even Pixar, I don't know if any of else has seen it, there is a coming-of-age movie called Turning Red that introduces the idea of a monthly cycle to very small children. So, you know, this is great. This should be fantastically welcome because, as we've already said, despite more than 50% of the population having periods, mostly, and most of them going through the menopause, it's always been a bit of a kind of something that people don't talk about, or is just left as, hormones are just left as something that's the butt of a kind of a joke. So periods are really important, and also we're told to learn about them more. So our smartphones can track our periods. There are signs on the tube saying get a sensor, look at your blood glucose. We've had lots of people, including one of our speakers, saying go out, get a home blood test, know what your hormones are like, know how it affects your fertility. And for hormones do affect everything. Yes, they affect our sex drive. Yes, they affect our appetite. Yes, they affect our sleep. So they are really important, and yet they're kind of not talked about, or haven't been for a long time. And yet, despite all that sort of visibility, when I was thinking about writing this talk, I realised that the biggest challenge I face when I see patients is that they just don't know what's normal. They don't know what's normal for their hormones. Definitely don't know what's abnormal for their hormones. And they also don't know what, if it's normal and you don't like it, what you can do about it. And these are courtesy of my daughter, because I gave her names of patients and she drew pictures for me. This is just an example. These are anonymised, obviously, but this is Zara. And she was 24, and she was really worried about her body hair. She really perceived her hair to be excessive. She waxed her facial hair about once a week, and it was generally her top lip and her chin. And she was really, really disturbed by the hair on her arms. So she had had an ultrasound when she was about 16, because they'd had query appendicitis, and someone had said, oh, you've got some cysts on your ovaries. And so she had then done what many people would do, which was look on Google for bad hair, cystic ovaries, and she had decided that she had PCOS. And I'm pretty sure everyone in here will have heard of PCOS, polycystic ovarian syndrome, a condition which I could give you a whole afternoon on why I think it's an awful title for something. But anyway, this was what she thought was the problem. So she went to her GP saying, I have PCOS, what do I do about it? And her GP was really thorough. Repeated the scan, because this was 5 years later, and it didn't show, her ovaries looked completely normal. Did a whole panel of which were normal. But was really concerned that maybe something was being missed, and so referred her in to see me to make sure, was there something else going on? Now, I have to say, when I saw Zara, I was able to confidently tell her that her hair was normal. And yes, as endocrinologists, we do have a chart to look at your hair, okay? But for her, and it really came down to her arms, looking at her arms, she has, and everyone look at your arms, you've all got hair on them, okay? But she was convinced, because when she looked online, she thought people should have absolutely no hair on their bodies. And I mean it. It didn't matter showing her my arms or saying, what about your friends? For her, this was absolutely, she just thought this must be a pathology. Now, I'll support whatever a woman wants to do to her hair. Wax it, dye it ginger, you name it. But I think that what you don't want to do is give someone a pathology when actually it's normal. And I think that we've got to be really circumspect about where people get their education from. In a sort of similar vein, let me tell you about Lucy. There you go, pick number 2. So Lucy also thought that she had PCOS. So she had stopped the pill during COVID, because lots of people did, it's fine. And her periods didn't come back, which is not uncommon for a bit. There's a lot of, if you stop hormonal birth control, your periods may not start for a little bit, and that's okay for a while. But they just didn't come back, and then COVID happened, and let's face it, for 3 years, sort of things that didn't happen, we all shrugged and got on with it. And then about a year ago, she started getting really bad spots, which she'd never had. She hadn't been a kind of teenage acne sufferer, but suddenly she'd left university, she was going to get a job, and she got really bad acne, and this really freaked her out. And so she did what many people would do, Google. No periods, acne. What you get is you get a label of PCOS. Now, she wasn't particularly fussed about the lack of periods. In fact, she thought this was fantastic. But she was really distressed about going to job interviews with acne. So she went to her GP, who then referred her on to see me to say, was there a hormonal cause for her acne? Now, at the moment Lucy walked in, I pretty much could tell her that she did not have PCOS. So Lucy had a body mass index of about 17 kilograms per metre squared. I'm sure most of you know, but really we're looking at anything above, I think what's called the healthy cutoff now is about 19 to 25. We can argue about the validity of a BMI another day, but ultimately she was very slender. She was underweight. And her loss of periods was not because of PCOS, but because she had something called hypothalamic amenorrhea. Basically, she was so thin and she was so stressed that her body had shut down her reproductive axis. Because, let's face it, in a kind of caveman brain sort of way, if you're in a famine, you don't want to get pregnant, okay? And so I was able to tell her that this wasn't as simple as me, and her acne was just acne. Sometimes that's all there is to it. Now, it takes someone much cleverer than me to unpick eating disorders and psychological distress. And as we've already learned from many of our speakers today, that is a lifelong journey. She does need HRT. I'm treating her with the same hormones that actually her mum, who came to the second appointment, they've gone on the same HRT, just to give her a bit of physiological backup while she's going through this. Because when I did a bone scan, and what's really important is that you get estrogen, and when your periods aren't happening, you don't have estrogen. She's got the bones of a 62-year-old rather than a 22-year-old, and we're trying to fix that whilst everything else is going on. Okay, so I guess there was, in some ways, these two gave me hope because, unlike many of the women that we've heard about from some of our other speakers, they got to see me. They knew that there was something wrong. They went to see their GP. Their GP went, I think there might be something wrong too, go and see an endocrinologist, and that's great, but lots of women won't. And the World Health Organization said that PCOS affects 8 to 13% of women of reproductive age worldwide. I'm not going to guess, but look around you, someone sitting next to you, 1 in 10 of you basically will have a diagnosis of PCOS. But how many of those are not PCOS? How many of those are actually, as we've just talked about, other things? The Women's Health Strategy for England from 2022 has said women should know, well, girls and women should know more about PCOS. What does it mean? What does it look like? We've heard already about how important it is for gynecological cancers. It's a risk factor for diabetes. But there isn't a lot about what that education entails, and that is why people resort to Google, and I understand that. And I had a really good Google hunt for what does that education entail, and I couldn't find a lesson plan for Year 8 PSHE telling people about PCOS, and my daughter flatly refused when I offered to go in and do the sex education talk. I think we've got a long way to go on that. I know maybe I'll get some of the other speakers here. She might take them more seriously. But I think, as we already heard, PCOS is often framed. I mean, this is all written as if it's a gynecological problem, but as we've already heard, it's an endocrinological problem. And if we only focus on basically, as a woman, your hormones mean that you bleed, and all we say is it's gynecological, we miss all the other bits that hormones give us, okay? And so I think we need to really support education about the whole range of hormone problems. And going on to probably the most important hormone issue, and I really would be failing as an endocrinologist and a diabetologist if I didn't talk about that, was it's really striking that there's nothing at all in any of this, and as far as I could see in any government document about education about diabetes. So, as you may or may not remember from some GCSE biology many, many moons ago, diabetes is a hormone problem. It's a hormone problem because it's driven by insulin, and insulin means that sugar in your blood gets put into your cells to use as fuel. Simple as that, basically. And there are about 3 million people in the UK, it's more than that actually, who have type 2 diabetes. So that's the common one. It's the one that's associated with being overweight. Is the sort of way that people frame it, okay? And it means that your body produces insulin, it produces the right hormone, just that hormone doesn't work. That contrasts to what we call type 1 diabetes, which is where there's an autoimmune condition and your body doesn't produce insulin. Very distinct because they cause very, very different, have very different treatments, though often the outcomes can be the same. And I think what's really striking is that of those 3 and a bit million people, 1 in 20 are under the age of 40. So unlike, and I did check the GCSE biology curriculum while I was writing this talk, it is not a condition of old age, which is where in the 6 points that they had about diabetes is one of them. And though it's not a condition of old age, and it is definitely the most important endocrine and hormone condition out there, if you look in Grazia or any other health hormone for women social media post, no one talks about diabetes. And yet, young onset type 2 diabetes is really significant. It's really dangerous and it's really difficult to manage. I think we're going to hear shortly about how important it is in pregnancy, and we've already talked a lot about pregnancy, and we're going to learn, I'm sure, about how much it's related to babies having congenital malformations and stillbirth. And I run an antenatal diabetes clinic, and these are, without hand on my heart, the hardest ladies to look after. But there's so much more to that. So if you develop type 2 diabetes when you're 60, on average you die 7 years earlier than someone of the same age who doesn't have diabetes. If you develop type 2 diabetes when you're 20, you die on average 16 years earlier than someone that doesn't have diabetes. And it's also the leading cause of blindness, of amputations, of kidney failure, needing dialysis. So it's got a huge health impact. And yet it can be completely asymptomatic. And it can be completely asymptomatic until really late, until too late. So just to hang this on a final picture of mine, so I want to talk about Ankita. So she is 28. I met her, in December, I think it was. Her diabetes only picked up because some very curious junior doctor checked her blood test after her 5th miscarriage. Now, diabetes is not a massive risk factor for miscarriage, so this wasn't part of any screening. In fact, there's really little screening out there for young people to have a check for diabetes. Even though Ankita had a really strong family history, so her mum developed type 2 diabetes in her 40s, she had an older sister who developed it in her late 20s. There's no sort of mechanism that would mean that she was automatically summoned to her GP to have a blood test. Instead, she would have had to go out of her way to do it. And I think, as we've already discovered, so type 2 diabetes and young onset type 2 diabetes is more likely to affect women. It's more likely to affect women from Black and Asian minorities, and it's more likely heritages, and it's more likely to affect people from areas of greater social deprivation. Already the people that are least likely to go and seek healthcare professional input. So that's why I wasn't surprised that she didn't know about it. And yet, when, as I say, she had this blood test fortuitously, she already had kidney disease. She's already got significant problems at the back of her eyes. And her blood sugars levels were in what one of my colleagues politely calls the death zone.
Not any symptoms?
No, none at all. None at all. So for all the out there going, are you losing weight? Are you really thirsty? Are you weeing lots? She had none of them. And I'd say it's great when people come in with that. But I'd say that the people I see with young onset type 2 diabetes, they don't have symptoms. It's picked up coincidentally because something else has happened and someone else has prompted them to do it. Or it's been, most people it's just been as part of, someone will have been doing a routine something, and then doctors were quite lazy and they just tick all the boxes. There'll be a form and everyone will go tick, 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 and it will come up as a surprise. And that was exactly the case here. Now, she's seeing me really regularly because she really wants to have a baby. and I'm working really, really hard to get her, as we'll hear, as fit and safe for pregnancy as possible. But despite that, I know I will never fully be able to reverse the damage that already exists to her kidney and her eyes. Last year, the NHS announced a really ambitious and fantastic new programme to give extra funding to help care for people who have been diagnosed with young onset type 2 diabetes. And that's money that hopefully will lead to more input so that someone like Ankita her complications don't progress. And the NHS health check, which is supposed to be rolled out for everyone over 40, you're supposed to get a call every 5 years to be checked. I'm waiting for mine. Is looking for diabetes. But unfortunately, neither of those will pick up. Ankita would never have got diagnosed in either of those, because those are either treating someone that's got a known condition or picking it up late. And so we've got this big gap. Even in there's a recent European guideline on fertility treatment. And even there it says, for people going through assisted reproductive techniques, IVF and for most people, don't bother checking for diabetes unless you're over 35 or obese. So we've got a large population who are a captive audience, and yet we don't automatically test them. So where does this leave us? Well, I think we've already talked a lot about education and having reliable education resources. But I thought, really, given that I've got an audience of predominantly women, as we've talked about, and we can debate about the young and not, here is my top tips for you, okay? Get enough vitamin D. I know I haven't talked about vitamin D. Vitamin D is a hormone, though. It's made by sunlight on our arms. It's February, it's London. Anyone? Yeah, none of us have enough vitamin D. So make sure you have enough vitamin D. It's really good for your bones. It's really good for your immunity. It's really good for your well-being. So my top tip, number 1. Number 2, know your own body. And for those of you with daughters, and really I thought about her while I was writing this talk about what I want my daughter to know about, is know your own body. And we've talked a lot about knowing what is normal and abnormal and trusting it, but also learning what other factors affect your body. So the second case I talked about, knowing how much stress affects your body. Knowing that when we're tired, and if I asked everyone to put up their hands who's tired in here, I'm pretty sure I'm going to get a 90% response rate. That doesn't mean that all of you have a thyroid problem or a cortisol problem. We have busy lives, and we're all juggling careers and fertility and kids and other things. So being tired is common, and that can often affect our other areas of our lives. But so knowing what is normal and where the rest of your life is affecting it is important. Also, making sure that people don't realize that what's on TV is normal. Being hairless, not normal. Think about diabetes, because if you don't, at the moment, no one else is going to, okay? So if you've got a family history of diabetes, particularly if it's young onset, so if you've got relatives diagnosed in their 20s, 30s, 40s, if you're thinking of having a baby, just get checked. It's one blood test now. It used to be a whole palaver. It's now one blood test. And the only way that we're going to improve outcomes for people with diabetes is picking it up earlier so we can get treatment in earlier, so that we can use the NHS diabetes prevention program. We can roll back things, but that only works early on. And I think if you think there's an issue with your hormones, do ask for help. I think I have to be a little bit circumspect about getting your own checking at home. So I'm wearing a glucose monitor. I don't have diabetes. I'm doing this because I really wanted some normal data to show some medical students and to show my patients, because what we need to know is how to interpret it. And that's the issue with getting stuff done at home, is that you need to know how to interpret it. I had someone who had one of these on, because it was a man, actually. I will go for that. He was a man. He had seen an advert on the tube. He thought this was a good idea. He'd see what his sugars were like. He called an ambulance because it went blue, which is low, at a totally normal level. And they brought him into hospital. We went through a whole palaver of things. So, I mean, I know it's a bit flippant, and he was actually, he then booked an appointment to come and see me afterwards, because he was still not convinced when the A&E doctors had said, this is all fine. But in all seriousness, I think it's really good to be curious, but actually knowing how you interpret things, and therefore also not being mislabeled. I think there are some companies out there that will give you results. There's one particular antibody level which will come back and people will be flagged as having a major problem. And I go, that just means you have a thyroid. Okay, it's not a significant, it's just normal. So knowing how to interpret it is really important. Okay, thank you.